So our next speaker is Richard Kimball from the United States, and Richard's going to be presenting today on how we can support the quality of life of carers and subsequently people affected by ALS. Richard.
Thank you. Thank you for allowing me to speak today, and thank you for noting that New Mexico is still part of the United States. I appreciate that. That often mistaken. Don't need a passport still. So just to say, I will introduce by saying I am at the University of New Mexico College of Nursing. I am a nurse myself. I worked in ALS clinical care at the Johns Hopkins University ALS Clinic for over 10 years. And that's where this research was done. Our objective for this study was to determine the significant factors that affect quality of life for carers and PALS in order to make clinical recommendations to providers on possible improvements to quality of life. The policy issues, and I apologize for this being very ethnocentric in terms of the United States, but this is the policy that I know. As we know, ALS affects adults working in retirement age who become disabled and access disability benefits. If they happen to be under 65, they can access things like SSDI, which is Supplemental Security Income, SSI, and SSDI if they've worked into the system. And for health insurance, they would get Medicare or Medicaid. Over 65, of course, we have our Social Security and our Medicare. In addition, veterans can access things like Veterans Administration benefits, which are now considered, ALS is actually one of the diseases that is accepted by the VA. In addition to, we can have a family member who gets ALS, there's often a loss of a job. This can cause increasing stress, anxiety, frustration, and depression, as we know. About caregiver burden, I won't spend a lot of time on this because other speakers have talked about it, but we know that it increases dramatically as the disease progresses and PALS become more and more physically dependent. It can also lead to decreased caregiver quality of life in terms of caregivers and PALS, higher morbidity and mortality for both, and even loss of employment, which can further exacerbate things like stress, anxiety, frustration. In terms of caregiver resources, we know that there is a Medicaid. Once people spend down, if they come on Medicaid and Medicare, there's an HCBS, which is a community-based services. I've never seen in the 10 years that I've worked with ALS patients anyone access this particular benefit. Departments of aging vary by county, usually in the United States, sometimes by state, and those can sometimes offer some relief, but it's few and far between. More often, of course, Veterans Affairs can provide many resources recently within the last 10 years. And things like hospice, of course, near the terminal stages can provide care. But much of the caregiving is left to informal or unpaid caregiving. The literature supports this. I won't belabor this, just to show the slide that, again, that caregivers' health is negatively affected with increasing caregiver burden, and there's higher societal costs. Quality of life, as we know from the literature, is not solely based on physical factors and disability. This is well seen in the literature. So what we really sought out to do is to look at a comprehensive list of factors to see which ones, besides physical disability, affect quality of life in both carers and PALS of ALS. We know that quality of life is not just a simple linear relationship, but it is really a rich, complex web of interrelated factors. We looked at the areas that are lacking in the literature, and we saw often that we controlled for a lot of things, depression, anxiety, physical disability, but we didn't often look at socioeconomic status and other things that can affect the social determinants of health. I think European studies are a little bit better in this. In the US, we're catching up, but I don't think we're quite there yet, asking some of these questions, which can be sometimes uncomfortable. So, after reviewing the body of literature on caregivers and PALS quality of life, we created a comprehensive list of factors from the literature, and we framed it within the precede-proceed model, and we did research at a large nurse-led ALS M&D clinic at Johns Hopkins. The ALS clinic at Hopkins has about 200 patients at any one time. Of course, that varies because patients fall out of care because they become too disabled to come. They die, and then new ones are diagnosed. And their caregivers, these dyads. It's a nurse-led clinic with a nurse practitioner as a director, so it's unique in that respect. Where I am now at New Mexico, for instance, a neurologist heads the clinic. It's multidisciplinary. We have case management with referrals in the community, support and educational groups often provided by things like the ALS Association and the MDA, and clinical trials. So it does attract a large, fairly young, and very motivated population. This is the proceed model in case anyone would like to know more about it. I can certainly talk afterwards. I'm just going to show it. This is the, I'm sorry, this is very small, but these are the factors that we decided to measure within our study. So it was questionnaire-based. We did it within the confines of the clinic. If people couldn't finish the questionnaires while they were in clinic, they were allowed to take them home and mail them back. They were provided a mailer for that. We had 32 factors for PALS and 15 caregiver factors, along with 4 communal factors that we used. And we did a cross-sectional sample of 104 PALS and 99 of the carers. I tried to get every carer, but some people did not participate in the study. So it was really a comparative descriptive study where we were looking at the primary group between different age groups and also between the severity of ALS. I got this severity of ALS modified scale from a study that was done out of Italy, where for the ALS-FRS score from 0 to 48, less than 33, I'm sorry, greater than 33, it should be, excuse me, is minimally disabled, 23 to 31 is mildly, etc. This is our methodology. The only thing I want to say with this, because this just talks about our instruments, we use the McGill single item scale for our quality of life. Caregiver burden inventory was for the caregiver burden measure. And we considered all factors that have a P of less than 0.10 as opposed to 0.05 because this is an exploratory study. Our results. In terms of our demographics, you can see the mean age is right in line with what the literature shows in the mid-50s, mid to late 50s. We had primarily more males than females for PALS, and the carers, again, were more females than males. Mainly white, not very diverse population, especially considering that Johns Hopkins is in the middle of about a 65% African-American community. And our response rates were 63 and 79% overall. Most people were married. Most were very highly educated, actually, in this group. At least 45% had college or greater of the caregivers and 49% of the PALS. Insurance for caregivers, no surprise, was mostly private because it's based on work status in the United States. For PALS, it was more diverse where we had more people on private insurance, on Medicare, which is public insurance as opposed to private insurance, about a 50-50 split. And fewer people in the workforce, of course, among the PALS. This is very busy. I just want to say, I'm going to show you this one actually because it's a little bit easier to read. The averages are highlighted. So the disability score is 34 for the average for PALS. That's fairly minimally disabled. That's just above the line of 33 for minimally disabled. They came about 3.4 times a year to the ALS clinic, and there's a breakdown between those less than 65 and over 64. So the older seemed like they came a little bit more, but not significantly. Quality of life overall was 6.8 from a 0 to 10 scale. And those with minimal disability rated their lives better, quality of life-wise, than the ones that had mild to severe disability. On the caregiver burden side, on the 0 to 100 scale, the average was only 16.1, so a fairly low caregiver burden score. And there were differences between those who cared for minimally disabled PALS and those who cared for mildly and severely disabled PALS. The average time caregiving was about 760 days, or just about 2 years, just under 2 years. In terms of formal caregiving, very few people used it, but some people who used formal caregiving, 3 people said they used it 24/7. So they hired someone to be there 24/7 with their PALS. But the average overall was 6.6 hours per week. And the hours of informal caregiving for caregivers was 20 hours a week. We did a multiple regression analysis, and the results were there were 17 variables with an R-squared of 0.28. This basically means that 28% of the variability in the caregiver quality of life scores was explained by this set of variables. The significant variables were caregiver burden, which had a negative association with quality of life, mental status, which was positive, and those that weren't quite significant but were approaching less than 0.01 for that p-value were years of caregiving and the caregiver socioeconomic status. These are the results. The adjusted R-squared is up there in the corner. You can see it, 0.28. Caregiver burden and mental status, these are the coefficients and the years of caregiving. Now, for those of you who aren't versed maybe in linear regression, here's a nice interpretation. So basically what this coefficient means is that as caregiver burden scores increase by 1 point from 0 to 100, the caregiver quality of life scores are predicted to decrease by about half a point, or about 0.5% for caregivers. So that's what that coefficient is, that negative 0.056. At the mean caregiver burden score was 16.8. That means at the mean, caregiver quality of life score suffers by about 1 point, or about 10% for the average informal caregiver, okay? This is just graphically to kind of show, in addition to caregiver burden and quality of life, this is caregiver burden versus disability. We can clearly see that as disability increases, caregiver burden increases. Additionally, caregiver mental status scores increase by 1. On the scale of a Z-score, which is a standard deviation, we can see that the quality of life scores go up. The same, we probably know this, but as caregivers gain experience over time, their quality of life is predicted to go a little higher. Interestingly enough, that one of the social determinants, the caregiver socioeconomic score, as it increases by 1, or better SES, the caregiver quality of life scores are predicted to go up fairly significantly at about 7%. For the PALS, the multiple regression, the R squared, that thing that explains the variability, is 0.53, or 53% of the variability was explained by this model. The significant factors were hours of formal or paid caregiving. It had a positive association, so the more caregiving you paid for, the better you rated your quality of life for PALS. Physical functioning, the better your physical functioning, the better your quality of life. Spirituality, religiosity tended to go up with more resources. And mental status also had a positive association. These are the coefficients, as you can see, for the significant factors. So, in terms of interpretation, as the weekly hours of formal caregiving increase by 1 hour per week, PALS quality of life scores are predicted to go up by 0.013 points. So what does that mean? It's a fairly modest effect when you consider that the mean was about 6.6 hours per week of formal caregiving. That's only, again, less than 0.08 points in the McGill quality of life score. So that's not very much. But when you consider, like for the 3 PALS that use 24/7 caregiving, 168 hours, that's an additional 21% or 2.1 points of quality of life. And this is just to show you that one of the reasons why our mean was so low for formal caregiving in the bottom left-hand corner is that several people didn't use formal caregiving. Again, this is a minimally disabled population, so this is maybe something we want to look into the future. You know, can the access to resources to provide for some relief for caregivers, can it increase the quality of life for both? So again, as PALS for the interpretation, as the spirituality scores increase by 1 point, it's almost a 1% gain in quality of life. Also for physical functioning, as we go up 1 Z-score, we increase. So we had a small population. It was wealthy and highly educated, but we were still able to show that 28 and 53% of the variability in quality of life scores are explained. But there's still much work to be done. We should make sure that for caregivers and PALS that we intervene and assess mental status, things like depression and anxiety, that we support caregivers with specific support groups, we assess the mental status regularly and offer early treatment. Of course, one of the barriers to this is we're not reimbursed for caregivers, and that's something on the policy side that we need to work on. We need to assess the spirituality, and we need to make sure that people have access and assess the needs of caregivers and PALS, especially early on and vulnerable when they're young, when they could lose their job, when they can be more under stress and have higher anxiety at the beginning of the stages of the disease, and when they're still coming to the ALS clinic. We want to increase the sample size for the future, enroll more diverse clinic populations in different regions, and we want to explore the social determinants of health that may affect. Thank you very much. I'd just like to thank the ALS Clinic team and my dissertation committee.
Thank you, Richard. Thank you. Okay, questions in the room, please. Okay, yeah, we've got one towards the back.
This is sort of a general question. Are any of these slides and PowerPoint presentations, are they going to be available to us after the conference?
I'm not sure the conference necessarily does, but I'll be more than happy to share. If you approach me, I'll just give you my card and you can email me. I'm more than happy to share anything.
I'll just find the answer for your question, bro. So there's an audio recording being made, and we will make the audio recording and the slides available to all who's attended. Okay, any further questions for Richard? Yeah, one down at the very front.
Claire Flaherty from Penn State's ALS clinic. Given the last presentation and the data on the lack of perceived relevance or significance of the psychological support, psychologist support, and your point about the importance of assessing and monitoring the mental health status of both the caregiver and the patient, can you address how you see the ideal approach to that? Both at the time of initial assessment of patient and caregiver, the time of diagnosis, and then throughout the course of clinic care.
Yeah, ideally, we would always look at and approach it as a dyad or even as a community when someone gets ALS, and we could write a nice big map about who our social supports are. I think that's a very difficult thing to do in a very busy clinic. I wish that we use standardized tools. I think that would be the number one thing, is to come up with some kind of standardized tool that we could all use and looking at the same thing in terms of definitions. That's ideally. I think what stands in our way in terms of policy is that we're not reimbursed to see the caregiver yet. As the gentleman mentioned, like with hospice, hospice, part of the benefit is that they get to follow up with bereavement care for 1 year with the caregivers. That's fantastic. Now, only if we could get something like that, policy change. Of course, with everything going on in health reform right now, I doubt that's going to come in the near future. Medicaid expansion is the big thing, but that would be ideal, is if we could do that, if we would get reimbursed to follow both. Because it really is, integrated. There's no way to separate it.
Okay, question in the middle.
Yes, my name is Darlene Knight. I'm with the Riverside Medical Group ALS Clinic in Newport News. My question is, what do you do about those patients who show up who don't have any support, who may show up at your clinic alone for the first several visits? What do you do? How do you recommend great support for them?
Yeah, that's a great question. We've certainly run into this. We've run into patients who show up for a couple of clinics and then they disappear, and then they come back, and then they're usually, extremely, many problems. I had one guy show up who could barely use his arms, who had driven to clinic from Washington, D.C. to Johns Hopkins to Baltimore. It's always a challenge, and I think you have to take those individually, and you really have to look at the resources that are available and refer to anybody and everybody. Those are, one of the ones you want to hand over to, a full-time social worker and a case manager. I wish there were the resources available in our healthcare system for case management, especially of these very difficult patients. I think in the long run, we would actually save money if we would case manage these patients and give them the resources they need, because unfortunately, we see time and time again, these patients end up in the hospital at least $2,000 a night, and sometimes they get vented, and sometimes they get feeding tubes, etc., emergently, which is never ideal. It's like that unexpected death difficulty. It's very, very challenging, and it uses a lot of resources and a lot of our staff time, as you probably know.
Okay, thank you, and thank you again, Richard, for your presentation.